You're watching 2024 It's a Wrap, produced by GP Supervision Australia and presented by Dr. Simon Morgan and Dr. Jess Wrigley. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
We are endeavouring to make it a fun one in the Christmas spirit and really base it around a bit of a quiz, bit of a review and recap of the webinar program for the year, remind you of some of the pearls of wisdom that were instilled over 2024. What I would ask you to do is to get a pen and paper because you'll need to write down your answers. We are going to take you on a bit of a walk through the last 12 months. And so by the end of the session, you guys will review a bit of the selected content from the webinar program that we've covered. We'll be using that as a bit of a trigger to point you to some GPSA resources, but also from the consultation board game. And this is an educational resource that we have been promoting over the last months. We've been showing this at a number of conferences. We've been talking about it a little bit. For those of you who are unfamiliar, let me talk about the game. It is a board game. It's an old-fashioned type educational activity where you sit with peers or with learners and there's a planned view of a general practice, and a bit like Monopoly, you move around the board, moving from room to room and seeing patients as you go. The aim of the game is to get to that room on the bottom right, which is the tea room, where there's some cupcakes cooked by a very kind medical student, a grateful learner in your practice. In the time Jess and I have played this game with many groups now, nobody's ever quite got there because it does take a little bit of time, but that's the aim. And at times you may be seeing patients, or you may indeed be pulled into the treatment room to see a patient with the nurse and answer some knowledge questions. The spinner is the mechanism by which it tells us what happens. And of course, just like in a real general practice, most of the time, your next patient arrives and you see them, and by doing that, you move forward a room. Occasionally, there's that pleasant occurrence where a patient doesn't attend and you get to jump forward 2 rooms, or indeed, sometimes as a fit-in patient, you stay where you are. And as I say, sometimes you end up to the nurse call. And so this is a game that we developed for GP training really, but we see it having great relevance for medical students, pre-vocational learners, and even, I guess, peers. And so most of the time it'll be a consultation, not unlike Sabine, and you pick up the card and you may see the scenario there. And Jess and I thought very briefly we might just give you a little bit of a demonstration of how that might go, because really this is about a real nugget of a consultation skill, lasting only 60 or 90 seconds, but of course, really importantly, a little bit of feedback. So this is Sabine, 39, moderate depression. And of course, we encourage people not to take the history from the beginning. It's going to take too long. It's just that picking it up from that point in the consultation. So she's keen to commence antidepressant medication. And so you might ask your registrar, in this case, Jess will play the registrar, about how she would discuss with Sabine commencement of an SSRI at this point of the consultation.
Hey, Sabine. So I understand that you are keen to start medication for your depression, and I think that's a really reasonable thing to do. I know you've given psychology and lifestyle options a good go and feeling you're needing something more. And I think it's important to know that starting medication is a very worthwhile thing to do. It's certainly, some people worry that it's a failure or something like that, but depression is an illness just like anything else, and sometimes medication's required. So we'll look at starting you on a medication that's commonly used for depression. It's in a group of drugs called an SSRI. You may have heard of serotonin, which is an important chemical in the brain. It can help with mood and sleep and that sort of thing. And basically this type of medication helps, lift up the levels of the serotonin in your brain. So we'll start you on a fairly low dose, because sometimes you can get some side effects early on, like nausea, headaches, feeling a bit off. But then after a week or so, you should be able to pick up your dose onto a sort of more stable dose, and we'll keep an eye on you. Maybe in a couple of weeks we can check back in and see how you're going. But then after, a week or two, most of those side effects, like your nausea and headache and dizziness, they tend to wear off for most people. And I think it's important as well that this doesn't replace psychology. You keep going with seeing your psychologists and, keeping up with your exercise and everything that you've been doing.
Okay. Thank you, Doctor. Now, if Jess and I were playing this in the real world, and the game actually has a timer, which goes for a couple of minutes, because we really do encourage this to be brief, punchy snippets of an encounter, then there'd be an opportunity for feedback, and there might be 2 or 3 other registrars listening in, there might be another educator or 2, and I would proffer some feedback, how you felt Jess went there, playing that role of maybe a GPT-2, explaining that. Obviously, it's a little bit artificial, but it just allows the opportunity to observe particular skill around explanation in that particular setting. And I might say, Jess, look, I really liked the way that you were, I think, very patient-centered. You included those other elements of depression care. You explained to me how the medication would be started and that there might be some mild side effects initially, but they're likely to disappear and I could then increase my dose. So I did feel I had that level of confidence around commencing it. The game instructions, I think, is 1 or 2 positive things, but certainly one thing that you may do differently or that could be added. And I guess it's always maybe worth talking about significant side effects that may warrant the patient coming back. I mean, having said that, you did ask her to return in a couple of weeks anyway. So again, in the interest of learning and teaching, I might say what might they be, and we can have that discussion. So we see this as a fun way of building some of those consultation skills. But thank you, Jess, for that.
I was going to say, I left out a few things. Like I didn't talk about suicidality or more long-term side effects, but that's okay.
The other type of card that you can pick up playing the consultation game are the knowledge cards. And these are very much clinical knowledge. And these are the things that may preclude you moving around the game board. It was interesting coming to thinking about gamification of an educational activity like this. And we didn't want to be punitive around people maybe performing poorly on a role-played case and therefore having to stay where they were. But we figured clinical knowledge is a bit more black and white. And so that was a reason somebody may progress or not progress. And so cards like Gina, who's 48 with poorly controlled blood pressure, and you note she's on escitalopram. So another SSRI question, and we inviting sort of responses to that. Do SSRIs increase blood pressure? So right at the beginning of the year, Duncan Howard, who's an academic GP from Melbourne, and I ran a session about alone general practice. And this was alluding to that TV show when they drop people into the wild and they have to survive with a few items in this very sort of difficult inhospitable environment. And Duncan had actually written a paper around this very experience of new GPT-1s arriving in the practice. It was a great webinar, and we would really encourage people who haven't seen it to watch it, maybe even for GPT-1s to see it. All the webinars are available on our website. But in that webinar, we presented a scale about how registrars are presenting at the beginning and then maybe as they experience their first weeks in general practice. So the same webinar, we discussed a number of survival items that I was referring to. In the real show, it might be a sleeping bag, it might be a bush knife, it may be some paracord. But we came up with some items that we felt new GPT-1s could use. And we presented a list of these. And there are 2 that I'm circling here. Why did we highlight ice and a dustpan and broom? For what purpose might a new GPT-1 in the practice need, or at least make some reference to these things to help them survive the early weeks of general practice? And so question 4, Janice, she's 77. She's got a hot and painful right leg for the last 72 hours, severe pain and fevers. She looks unwell. The leg's hot, violaceous, I think means purple in colour, below the knee, with an area of dusky crepitus, which is exquisitely tender. What's the most likely diagnosis in Janice? The not so simple consultation.
So in this webinar, which some of you may have attended, we were covering a few, certainly not comprehensive, but a few of those sort of consultations which may seem very kind of straightforward and quick and easy. And sometimes the patient might even say, this is an easy one for you. But actually they do have some sort of underlying complexity, which perhaps early term registrars may not recognise. as written there, superficially straightforward, but potentially complex and challenging. So we presented 5 different types of consultations that sort of meet these criteria. Can you remember 3 of those 5 consultation types?
And clearly you may not remember, but hark back or at least have a think. What sorts of encounters fit that bill? Patients say, as Jess says, simple one for you today, doc, and the registrar's thinking, oh my goodness, really? Not for me. And so that one's got 3 parts. And question 6.
Okay, so question 6, one of the knowledge cards from the game, presents Rani, who's 46. She's had poorly controlled blood pressure and you suspect secondary hypertension. Hypokalemia is a common feature of primary aldosteronism, true or false?
So that's question 6. So in May, we talked about PQRST, and this is now becoming, I think, relatively well known as a simple framework for problem case discussion in the practice. I imagine many of you are familiar with this model, and some of you indeed might be using it, something we've been pushing very hard at GPSA because we think it has a lot of merit. So maybe this is a straightforward one, but what does the R stand for in the PQRST method of problem case discussion? And question 8, Chloe, aged 21, has a 3-day history of pelvic pain suggestive of pelvic inflammatory disease. Endocervical swab PCR testing for Mycoplasma genitalium is indicated. Yes or no? And this is, I think, an interesting question because the role of Mycoplasma has emerged significantly over the recent years, and its place in testing is still quite confusing. And not that it's one of our resources, but the STI testing guidelines, which I know many registrars use very regularly, is an excellent source. Not that you should be looking at those right now because you might actually see the answer, but we can look at them later. In May, Gerard Ingham, who many of you will know as a peer and an experienced medical educator and the person responsible for supervisor professional development for the RSCGP, he presented a webinar on managing uncertainty. Gerard's webinar at the time was based on a paper that was published in the AJGP, and it was a new model really of how to manage this, like, a quintessential concept in general practice, how to manage uncertainty. And he talked about a number of R's. So how many R's, and some of you may have seen his paper in the last few days or remembered him talking about it, how many R's does Gerard refer to in his new framework of managing uncertainty? And of course, everything we're talking about tonight isn't just some esoteric kind of fact. We're really hoping it's bringing stuff forth that you've either come across or you may like to look at and think about with your registrars, because this is a really interesting, simple approach that you can use in practice. Now, mea culpa here. When I was looking at these slides, I realised that I have gone from May to April, so they're not in strict chronological order. I'm sorry for that. But we did a session in the middle of the year at least, and it was around ECTVs. And this was very much for supervisors being responsible for utilising the ECTV for their registrars in the way that really maximised its educational utility, including talking to the visitor about the registrar's performance, including reading the report, including talking to the registrar about how it all went and what learning needs may have arisen. Now, apologies to ACRM supervisors because this was a bit RSCGP centric, but the RSCGP has a number of competency areas that they use in their workplace-based assessment. And again, you're very welcome to guess if you have no clue, but we talked about that in that webinar and how you as supervisors really need to think broadly about your registrar's performance, and the visitors try to do that too and have that conversation, because we so commonly just default to the clinical, maybe the communication skills, but there's so many other things. So how many competency areas are there in the RSCGP WBA rubric? The knowledge card, question 11, MR29 has dyspepsia and you suspect Helicobacter pylori. What is the sensitivity of a correctly performed urea breath test? And there's some figures there, and one of those figures is correct, but I guess you could say not very good, pretty good, very good, or really very excellent. Which of those is it? And again, I know we've had some feedback about some of these questions being a bit too specific, but I think having a sense of specificity, sensitivity of commonly used tests like this, how often something's going to be a falsely negative, is actually very important.
Okay, so on to a more recent webinar, which was a really wonderful one. I think if any of you haven't seen it, definitely recommend, on clinical yarning by Dr. Karen Nichols. So we've got a question on that one where she talked quite a bit about the 3 elements of clinical yarning and, how to go about each of those. And so our question is, what are the 3 interrelated elements of the clinical yarning method? I don't know, I was thinking a lot about this concept, with the Seaway, Aboriginal and Torres Strait Islander patients. And I think it's something, if you work in this space, primarily it's something that I think, even if you weren't doing as a sort of deliberate structured thing, I think with time you start to realise that this is the way that seems to get the relationship built best and best outcomes. But it is really nice to sort of have seen it kind of documented in a more explicit way.
And again, guesses are welcome, and so you might want to be a bit intuitive. And a clue, they're really just 3 single words. So it's not some long description.
Not a long descriptor. Yeah. And it's all, very relevant to what, all related to stages of the consultation anyway. Again, we've got another knowledge card from the game. We've got Maggie, who's aged 51. She's usually fit and well. She presents with acute dizziness, nausea and vomiting for the past 18 hours and describes a sense of the room constantly spinning. Her hearing is normal. What is the most likely diagnosis? Any of you who've done the KFP perhaps not too many years ago and now finding yourself as supervisors may be getting some uncomfortable flashbacks reading key feature type questions.
We really do make an effort to make the webinar program relevant, really high quality, good speakers, but I think we finished on a real high this year. Jess has mentioned Karen Nichols' webinar, which unfortunately neither of us were able to attend live, but have seen since, and that was relatively recent. This was another extraordinarily good session on a topic that I think has been really not well considered over the years around identification and support of registrars who may have neurodivergence, in particular people with autism or ADHD. And Katie spoke so well on that very recently. She's an educator from Far North Queensland, and this was so practical and really eye-opening, and the feedback was fabulous. So again, a real plug to visit our website and have a look at that. It really, to the point where people were saying in feedback, for years and years and years, I've wondered why my registrars perhaps were struggling, and this has just perhaps been the answer, and potentially, I've missed that. So in Katie's webinar, she talked about the SPACE framework for meeting the needs of autistic people in the healthcare workplace, more broadly than GP training, and this is some work that's been done that she referenced. And again, very welcome to have a guess, because you may not know this, but what does the E stand for? And maybe just think about how you may support somebody with autism spectrum disorder in the workplace, or at least what aspect that you can help them with. And I think this is our last question, and with the sort of sub-questions, it all adds up to 20. So Les, age 38, has a 24-hour history of a hot, swollen and painful second metacarpophalangeal joint. And the question is, small joint involvement is typical of a gonococcal monoarthritis, yes or no? And as I say, I think with those parts, you should have a score out of 20, and we'll go through the answers in a second. So the second half of this webinar is very much pointing you to GPSA resources, recapping some of the content of what we've discussed. So the answers and a few resources. Knowledge card question 1. And so we've just started Sabine on her SSRI. Would we expect or be concerned about a rise in blood pressure for somebody who we start with an SSRI? And this is something I don't think I knew, but we looked it up, and there's a meta-analysis done that demonstrated that SSRIs do not affect blood pressure, while SNRIs led to a modest increase in blood pressure. And I don't know, Jess, as a GP, is that something you thought? So many things can contribute.
No, I don't think it's one of the main things that I think about when I think about this class of medication. Like, I don't think I'd even considered it really until we started digging into this.
But certainly, I think a really big plug, and one we can teach registrars about, is that we do see patients with poorly controlled blood pressure. They're on 1 or 2 or 3 agents, and you're thinking, oh, wow, is secondary hypertension here to blame? And you might start to think about other causes and investigating them. But always a review of the medication list, I think, is useful and I think commonly forgotten. Jess, this was a very catchy title. If anyone did remember this, I'd be really pleased. So
I mean, the pictures are there, right? Frizzle chicken. Love.
Do we give frizzle?
That's better. Frizzle chicken. No, frizzle's different from frazzle.
I think that's got to be half a mark.
A rooster is a type of chicken. So
yeah, that's half a mark.
Technically correct.
That's pretty good.
So this was really good because obviously we had a bunch of, new GPT ones. A solid half of them were a little anxious at the very least, I think. And I think a lot of them may fear that it's only them who's anxious, or they just need something to kind of validate their feelings a little bit, I suppose, and normalise that. And this was just a really nice, lighthearted way. Like it enabled people to relax a bit, to be able to open up a bit more about how they were feeling. This was, in orientation, so prior to them actually starting term. So it was good. One of my registrars who's about to fellow, actually, I never brought it up, but every time I would talk with him or do an ECTV or something, he would give me his frazzled Richter scale. So that was quite sweet.
Yeah. So Jess is referring to some work we did as RACGP educators in an orientation session, but we would absolutely invite you to use some version of this with your new registrars and get them to quantify how they're feeling, and then maybe ask them to do it in a few weeks and get a sense of whether they're improving. There's some good-looking chickens in that lot, I've got to say. But it's been a quite interesting, fun thing to do. So there's lots of survival items that we recommend. There's a net there for safety netting, which I think is probably the only common one between the contestants on the Reel Alone who are out in the wilds of Tasmania and our registrars to remind them to safety net. There's a urine jar that we encourage registrars to use to buy some time and get the patient to go off and do a spurious wee so that they can have a think about what to do and look it up on Health Pathways. There's a no button to decline inappropriate requests for imaging or opiates perhaps. There's a notebook to document patients that they may wish to follow up or learning needs. Patient information leaflets we think are fantastic for when the registrar is struggling to remember some clinical content and wish to use it as a bit of a scaffold as they work through it with the patient. And, oh yes, of course, well, that's the cream that we should be using. And of course, coffee is essential. And hoping that you might have made the link between ICE and ideas, concerns and expectations as a survival tip, asking what do you think is going on, asking the patient, are you particularly concerned about anything, or what were you hoping to get out of the visit today, even especially in those early weeks, can really make the registrar feel like they're getting to the nub of the patient's agenda. And of course, the dustpan and broom refer to Roger Neighbour's housekeeping. And we think about housekeeping for 3 reasons. Housekeeping of the mind, clear the mind, last patient's gone, prepare yourself, and the registrar should do the same thing for the next patient. Housekeeping of the room physically, of tidying up the desk, tidying up the bed that maybe have some ruffled paper on it, and tidying up the notes and just sort of having a bit of a sense when the patient comes in, you've waded through their past history, you've taken away all the old medications that are cluttering up the inbox or the patient file. So they're the answers that we're hoping for: ideas, concerns and expectations, and housekeeping. So 10 years ago, myself and 2 colleagues, which we still work with, wrote this article on general practice consultation skill tips. Some of you may know of this. I'm really chuffed that that's been used quite widely since then. But With Jared's article published a few days ago, in the same edition was something that Jess and I wrote on an update of these consultation skill tips. Not that you'd say a whole lot's changed in that 10 years, but we just added a number of other aspects of the consultations. And of course, our increasingly ongoing way updated consultation skills toolbox on our website and a range of teaching plans on consultation skills. So Jess, would you have got this diagnosis? I think you probably wrote the card, so maybe you would have. Have you ever seen this diagnosis?
No, I haven't. Except for on TV shows when everything's very dramatic.
I don't think I've seen this either, but they say that it is distinguished by necrotizing fasciitis by a disproportionate amount of pain according to the presentation and tenderness. So people, obviously this woman's got pretty advanced disease, I think, with crepitus, but if you're thinking, gosh, this cellulitis isn't getting better, and in fact, there's a lot of pain here and she's really tender, start to think of this, particularly, I guess, in people with diabetes or even subtle immune compromise. So, answer to question 4. We thought this might be a bit tough, wasn't it, Jess? But
I feel it's a bit tricky, but you never know. I mean, there's a whole heap of unfamiliar clinical scenarios, especially when you're a new GP reg. And many of you are probably already familiar with the Call for Help list, which I believe Jared Ingham generated a few years ago now, which is such a great resource, I think, for registrars and supervisors to discuss with their registrars, in their early days in practice. But anyway, we covered a few that are in that list as well as our own in the webinar, those 5 being fitness to drive, the baby check, a skin check, if someone's presenting for a general health check or screening, and a quick and easy script. So they were our 5. So if you got any 1, 2 or 3 of those, you can give yourself the corresponding marks.
Up to 3 marks, that's right. As Jess said, they are very much, somebody comes for a skin check for established GPs, that's straightforward. For registrars, it's like, where do I start? And am I going to miss something? But there are other common presentations, I think, that we can, as supervisors, be aware that it might be complex for the new registrar.
And I think the other thing to say on that is some registrars will be very cognizant of the fact that this is complicated or uncharted territory for them, but certainly some may not appreciate the perhaps hidden complexity of some of these and, those unknown unknowns and may potentially miss covering key aspects of these consultations.
Yeah, so an invitation again for those who missed or would like a refresher on this we covered that in this particular webinar.
So now our knowledge card with Rani and our suspected secondary hypertension. So the question was, true or false, hypokalemia is a common feature of primary aldosteronism? And it's actually false. So whilst it is certainly associated with primary aldosteronism, it's actually not common. So if you suspect it, but someone's potassium is normal, that certainly doesn't mean that you can rule out the diagnosis. So yeah, up to 37% across various studies. Again, when looking at this, I thought it was much higher than that.
Yeah. I think I remember basically that's the cardinal feature, and it's interesting when you see this.
I think if it's there, it certainly encourages you to go, yeah, okay, I think I'm on the right track. But
so I'm hoping many of you may have known this, and the rest of you might have guessed that R stands for reasoning. And as I say, I think this model's becoming fairly well known now, which is nice. I usually at this point say that I have been encouraged to turn it into the QPRST model, where a supervisor should be asking the registrar, what's your question, before they actually ask the registrar to present the case. But I actually think it's really nice for the supervisor to hear this problem representation, get a sense of the patient. All right, what particularly do you want me to help you with? And then the R, of course, is exploring the reason. The webinar we ran was based on a paper that was published a couple of years ago now. We've also turned that into one of our so-called how-to resources, so how to do problem case discussion. We've got about 5 or 6 of the how-to resources now. It's a suite of resources, essentially 1 or 2 page, based on teaching methods, very practical, sort of thing you can just reacquaint yourselves with very simply, and looking to expand that. And we're always an invitation to supervisors to contribute. So if there's anything you're keen to do with us, let us know. But that's PQRST. And I guess when we think about the R for reasoning, I was having a conversation with a colleague today, actually, and I said to him, the more I do of this gig, the more I realise that the role of supervisors and educators is pretty simple. There's only two things we probably need to do. One is to teach registrars how to drive, and by driving I mean how to drive the consultation, how to get in the car and go from A to B and do that effectively and safely, and indeed when the conditions are a bit sketchy, it's nighttime, it's raining, it's a dirt road, they can still manage that okay. And by that I mean more challenging consultations, because they just apply the same thing. So how to run a consultation, A, and B, how to reason, how to put it all together. And I think that's our job as educators and supervisors. And increasingly, I think there's a lot of other stuff that potentially kind of gets in the way, but for me, they're the core elements. To support your role teaching clinical reasoning to learners, we've got our guide, we've got our how-to resource, and this was based on a webinar that we ran as well. And a very big plug to read, to think, to play with some of these aspects of your work, because it is great fun and very much, what we do as GPs. And most of you may have come across the clinical reasoning game. Jess and I are a bit disappointed, because if we ran this webinar maybe in 6-8 weeks, we might be encouraging you to open up on your phone in a new app version. And this is the old game from GP Synergy, which GPSA now has the IP for. And for those of you who have seen it and used it, fantastic. It's a diagnostic reasoning game. For those of you who have not, it's web-based currently. You can just Google GPSA clinical reasoning game. You randomly choose a demographic card. And so our registrar's back, thank you. Our GPT2 registrar, who's done that nice job in the consultation game. And we're looking at clinical reasoning, and we choose a 55-year-old female, and we choose a presenting complaint, and she presents with dysuria. And if you wish to, you could say to Jess, you can use your anatomical model or a surgical SIVT or Murtaugh's prompt, or, some version of that. But what sort of differential might you come up with when we think about a 55-year-old with dysuria?
I guess thinking about the prompt model, and most likely, obviously UTI is the first one that comes to mind. Or considering that she's a 55-year-old woman, it could be something related to, menopausal atrophy. They'd probably be two of the main ones. And then in terms of must not miss, I think important to consider stuff like STIs, even though she's 55 and perhaps they tend to be something that we typically associate with younger people. I think it's important not to assume. Obviously, something like a bladder malignancy could present this way.
Thank you. You've applied a model. You've started to think of those things. But let's choose a general observation card, Jess. Maybe just this. How does your reasoning change? What does this do? This extra bit of information. And of course, it's a little bit inconsistent maybe with what you might have expected.
So just thinking about this one by itself, is she wearing the sunglasses because she's photophobic? Is she trying to cover up an injury? Like perhaps was there an assault and she's potentially got an STI or just trauma and perhaps bruising?
I could ask you a whole range of questions about, because there's that thing of are they linked? Maybe this is the reason she's come, but she's complaining of a more trivial symptom. And the last step in the clinical reasoning game is to choose a finding or a results card. And Jess, as our GPT2 registrar, how does that change your diagnostic reasoning?
So 55-year-old female with dysuria, wearing sunglasses indoors and tachycardic would make me more concerned for something significant. Is she septic? Has she been bleeding from somewhere?
Yeah. And going along the lines of domestic violence or bruising, or how might you incorporate a high heart rate?
I guess, anxiety, fear, that sort of thing as well. Yeah.
Of course, for those of you who played this game, you may get to a point where it all seems a bit ridiculous, but you can use it strategically too. And I'm hoping that even in that little demonstration, you could start to interrogate Jess's thinking, her reasoning, how she's approaching it. We better swiftly move through. So do we do a PCR for Mycoplasma genitalium in somebody who we think has PID? And the answer is true. And I think that is a bit of a change of practice in relatively recent times, but I would have to consult the guidelines to...
I mean, the distinction here is certainly about symptoms versus screening.
Yeah. And I think there's a lot of inappropriate use of that test in screening, as you say. Jared refers to 3 R's, and I must say, as I cut and paste this, I thought, oh, hang on, somebody's going to say it, but surely there's 4 there with the reassure. But his paper is actually about the 3 R's, and this looks about as simple as you can imagine, but it's a framework he's come up with, and a really nice one I think you could use with registrars. You don't know what to do, so should you review, should you refer, or should you treat and see what happens? Have a read of his paper, as I say, a good addition to some of the stuff we have, which is our guide on managing uncertainty in the swamp and a how-to guide. Now, there's a clue in the number here, although I'm sure you wouldn't have got it, but how many competency areas are there for question 10? And there are 10. And again, we're not in any sense attempting to go through all those, but just really a flag to say when you are doing your own direct observation or performance review of a registrar, random case analysis, or any kind of formative assessment, think beyond, the clinical and perhaps the communication skills to all those other aspects of practice. And this was based from a webinar on the ECTV. This is a bit of a passion project for myself, really trying to enhance the utility of these. And we came up with this how-to guide. So for you as supervisors who facilitate teaching visits of your registrars in the practice, have a look at this, because ECTVs are expensive, they're resource intensive, they're threatening potentially to a registrar, but they can be enormously educationally valuable. And there are ways, I think, to make that even more so, and this goes through some of those. It's good. It's a good test. It's actually worth knowing in context of other tests like serology and stool antigens as well. So it's a very useful test to identify H. pylori. So clinical yarning?
Yeah, so the 3 interrelated elements are the social yarn, the diagnostic yarn, and the management yarn. So all, stuff that we typically do in consultations anyway, but it's just a way of framing it and practicing those elements for this particular patient population. And yeah, definitely can recommend viewing that webinar to, improve your consultations with Aboriginal and Torres Strait Islander patients.
Again, a really nice framework, I think, for registrars to use and to think a bit metacognitively, what am I doing here? Really, this is the social bit. This is the social yarn with the patient.
And so now we've got our key feature, problem, question, and Maggie's most likely diagnosis is vestibular neuronitis, with the other sort of, main differential for those particular symptoms being labyrinthitis, but that'll have hearing involvement as well.
Katie spoke about supporting neurodivergent registrars, and she put a model up called SPACE, which I have no time and certainly don't have any experience of using. The E stands for empathy, and again, she spoke to this in the webinar. I would not in any way wish to diminish her excellent presentation by trying to cover it now, but she talked about this model, and it was a nice, again, simple one, I think, that registrars and ourselves can apply to learners in that setting. So E for empathy. And the last question was question 15, Les with his monoarthritis of this small joint. And it's actually false. Gonococcal arthritis more commonly affects the joints you see, and they're usually larger joints. Just again, to point to our resources, this is our main resource page. It covers the types of resources, teaching plans, guides, the webinars that we've alluded to, the how-to resources and the toolboxes. And we've got the consultation skills toolbox, and we've got the teaching and learning toolbox, which we encourage you to have a look at. All relevant for supervisors of registrars, and primarily written for, but increasingly for students and pre-vocational learners. We'd like to thank you hugely for your support and engagement over the course of the year. Jess, thank you for coming along tonight and co-facilitating.
My pleasure. Bit of fun.
And a very, very happy Christmas to you all. Safe and peaceful New Year. And we look forward to seeing you in 2025. Thanks so much. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.